presentations of today, but I'm sorry I was not able to be here for the presentations on the first 2 days, because I really like the title of our meeting, Global Responsibilities for Global Health Rights. It's a perspective that I share very much. Also, some people who were grumpy earlier about PowerPoints will be pleased to know I have no PowerPoint presentation to give. But listening to the 3 fine presentations this morning, it did strike me that they were good incremental presentations on a not at all adequate situation in addressing the right to health in the way that I will be elaborating it and that has already been discussed. It's not really sufficient, because if we go a better, more integrated, incremental but not much different, I don't think we're going to achieve what we need to achieve in realising the health MDGs and the broader right to health. As has been mentioned, we're coming up to a very important meeting next September, the high-level General Assembly meeting on the MDGs, and this will be co-chaired by Finland and by Senegal, and will, in a way, put us in a position of where do we go for the 5 years to 2015 to change, I believe, dramatically exactly how we're going to get to fulfillment of the MDGs within that timescale, and have the overall strengthening of health systems that we were discussing this morning. I do agree with the kind of experience that we've had in realising rights, working closely with Professor Paul Hunt and others, and why we're not making more progress. First of all, as I'm sure Paul emphasised, and it has already been mentioned this morning, it is important that the Human Rights Council now sees the issue of maternal mortality as a human rights issue. That is already opening up a much broader advocacy and involvement, which I'll come back to. I thought I might speak to the practical work we've been trying to do in the context of 5 sort of principles that outline a human rights approach. And the first one is participation and empowerment. Clearly, individuals and communities must be involved in health policy decisions that affect them, including decisions around sexual and reproductive health. And this means empowering women and girls to be agents for change. It means mobilising civil society, strengthening women's leadership capacities, and supporting girls' education and more focus on girls' health. And there's a very good report, as you know, that's just come out on the health of the adolescent girl. Gender equality is vital to addressing global health inequities. Now, when I heard reference this morning to civil society, and there was quite a lot of reference, I had a sense that the civil society that was being referred to was the civil society that delivers health services. That's an important part of civil society, but it's by no means adequate when we talk about the need to involve civil society. And some very promising things have happened. For example, Amnesty International has just launched a Demand Dignity campaign. And one of the central issues in that Demand Dignity campaign is to address maternal mortality, but to do it from a bottom-up community and individual women and women's groups perspective, to tackle, to demand access to family planning on the demand side, to tackle early child marriage, to address violence, particularly domestic violence, and the inhibitions of the woman and the girl child in the family, whether she can leave the home, what kind of independent decision-making she can do at all, land rights, property rights. So this is all a component that we need. We need women leader champions, Your Royal Highness. I was in Malawi recently, and I'll come back to the reason why I was there, and I met the Vice President, Joyce Banda. She is a goodwill ambassador of the African Union for maternal health in her country, and she takes it extremely seriously as Vice President. She had just come from a clinic where she found 80 women sleeping on the floor, and we were together, in fact, opening a maternity hospital in the Buela Hospital in the capital, where Irish funding and Norwegian funding had helped to provide a state-of-the-art facility. And as she went around, she nearly wept at the contrast between what she was seeing in this one facility and the reality in most of the other places for women giving birth, and being encouraged to move away from traditional birth attendants and move to these clinics and district hospitals which lacked proper facilities. So these are, I think, the wider components that we need. The second principle is accountability for rights. We must approach to a minimum 0.7% of ODA from higher income countries and innovative approaches. We need both, and it's not an either or, and I don't think people really were seriously suggesting it, but certainly I think it would be a move backwards to not have countries uphold their commitment. And I speak from an Ireland that has been wobbly recently, but I think wants to be on track and intends to meet the 0.7%. We rightly this morning discussed strengthening health systems and not so much a focus on vertical interventions. And one of the components of strengthening health systems is, of course, human resources for health. And I do believe we have to have, again, a holistic approach to this. We have to look at the brain drain of health workers, and we have to be much more responsible about it. And I'm glad that Sigrun and her Norwegian colleagues are here, because Norway, as she knows I often mention, is giving good example within the context of Europe, not the European Union, but the wider Europe, because Norway has been thinking ethically about the fact that it is unlikely to be self-sufficient over the next 20 to 25 years, and therefore it will commit to paying for those who come into the Norwegian health service. The United States is giving fast-track visas, as are other high-income countries, to fully trained doctors and nurses from developing countries. That's a complete development gain, cheaply, for those countries, but they haven't thought ethically about it. And we have a real problem, as I saw in Malawi and Tanzania, where I was promoting at the higher level work done by a number of partners, Columbia University, Trinity Dublin, a network of African partners, and Realising Rights, in looking at the role of mid-level providers, non-physician clinicians, in providing emergency obstetric care. And I'm sorry, you participated in a meeting that we convened in Washington on that subject. And it's very interesting that there's now evidence-based validation of the fact that these mid-level providers, if they have an enabling environment, provide the same quality of care as fully qualified obstetricians, doctors. So this provides for more hope. They will stay in rural areas, etc. And I was discussing that with the Vice President and Minister of Health in Malawi, and I had an hour-and-a-half discussion with President Kikwete, because he's taking extremely seriously that particular statistic and what Tanzania must do to bring it down. There is no doubt in my mind that this has to also be part of a wider social protection, the kind of insurance-based or holistic social protection that you have now in a country like Rwanda, because health shouldn't be a risk for an individual family that may drive them into terrible poverty. That's not a human rights approach. So we have to have a holistic approach to social protection. In that sense, human rights requires the prioritising of resources. And we looked this morning and saw that there isn't prioritising of resources for women's health and indeed children's health. And then my last point, which was touched on this morning, is human rights are everyone's responsibility. That's actually in the Universal Declaration of Human Rights. Article 29 says we all have duties to the community, but the Universal Declaration states that, in quotes, every individual and organ of society shall strive to promote respect for these rights and by progressive measures secure their universal and effective recognition and observance. And I'd like to end with a quotation from the chair of the Universal Declaration of Human Rights, and we marked its 60th anniversary yesterday, Eleanor Roosevelt. In a speech she made at Columbia University some 60 years ago, she said, "We will keep our minds open and we will be prepared to meet new needs and new circumstances as they arise. But we have to make a beginning, and the beginning can only be made if we really make the Universal Declaration of Human Rights a living document. Something that is not just words on paper, but something which we can really strive to bring to the lives of all people everywhere in the world." So if we're really serious in the summit next September, I think we have to be talking about a global health fund. I think we have to be talking about sustainable incomes for health budgets in the poorest countries that provide the real possibility of the kind of social protection that makes healthcare accessible to all. Either we're serious or we're not serious. But if we're serious about a human rights approach, then we do have to do more than a good incremental approach. We actually have to take a bit of a jump and make the full commitment. Thank you.
Thank you very much, Mary Robinson. I should now like to invite Jeffrey Sachs to address the audience, and then